So let me start with the first one by Dr. Bhatt, with the director of Mount Sinai Heart, joined us here last year. So happy to have him. And he is the Valentin Fuster Professor of Cardiovascular Medicine, the first Valentin Fuster Cardiovascular Professor of Medicine. He actually was also the Eugene Braunwald's Professor of Medicine before, and just coming from there, it has been tremendous, I would say, addition to our Mount Sinai Heart. So he's going to talk about, which we have a little bit discussed earlier, the interrogating the role of triglyceride in coronary artery disease, the newer therapies and superior outcomes. As you know, he has been a master of a few of the trials with the triglyceride, this all we call simply the omega fatty acids, but clearly will tell us where we are. Although over the years, we have concentrated less on the triglyceride. Maybe after today, we'll learn more and be more aggressive with the triglyceride. So Deepak, welcome. Thank you very much.
Great, thank you. Before I get started, someone had lost a Google phone. Did anyone see a Google phone out there by the coffee? If you do, please bring it to the front. All right, well, thank you very much for that kind introduction. Before I get started on this topic, these are my disclosures, and relevant to this talk is research funding from Amarin and 89 Bio, both of whom make drugs involved with triglyceride lowering. So I'm going to delve into the science in a bit, but I have to say we had a wonderful faculty dinner last night. And really, I've got to thank Dr. Sharma and Dr. Narula. I guess maybe Dr. Narula is still out there chatting and snacking, but it really was it's just like when you were kids, right? You were the harder worker. He was the one following you. I guess maybe times haven't changed, but it was really remarkable. Beyond the course, which I think is terrific and very well organized, just hearing the story of a friendship that had endured 50 years, I think is really what makes life worth living. So congratulations on that. I was reflecting, few things last 50 years anymore, right? Most marriages, they don't actually last 50 years anymore. Buy a house usually doesn't last 50 years the way things are constructed now. Most businesses out of business within 10 years. So really remarkable. That's right. It's not the old day of you work for IBM or Xerox your whole career, right? Nothing lasts 50 years. So really remarkable. Okay, so let's get to the topic at hand, which was triglycerides. Dr. Sharma himself alluded to the fact some years triglycerides have been in, other years they've been out. And what's the story now? Well, I go with what Peter Libby says. He says that they're in. That is, the weight of evidence really does support that triglycerides are indeed an independent causal risk factor for atherosclerosis. And was someone objecting? Oh, okay. I was going to say it's too early to object. I haven't even started yet. But to be very specific, it's not triglycerides, it's triglyceride-rich lipoproteins. Of course, those are measured in the blood as triglycerides, but the atherogenic parts, the triglyceride-rich lipoproteins. And I think it is different from, say, HDL cholesterol that most people right now are saying are bystanders, maybe guilty bystanders. But here we're talking about a causal risk factor participating in atherosclerosis. What proof is there of that? Well, this is from a Mendelian randomization study published a couple years ago in JAMA. And what we did in this analysis, and really it was Brian Ference from the UK that led this, was look at different genotypes that predispose to LDL or triglyceride levels, high or low. And what the study found was that genes that were associated with high LDL, or maybe I'll say it the opposite way, if a person had genes that were associated with lower LDL, well, that was protective against lifelong cardiovascular disease. Whereas if they had genes that were associated with triglycerides, it was the same thing, lower was better. But there was a key difference that maybe not everyone dived into if they read this paper. And I'm not going to go through all the statistics or genetics. It gets really complex, and if you don't like this stuff, boring very quickly. But the point here is you'd have to lower triglycerides by a lot compared to the amount that you lower LDL to have the same sort of risk reduction seen here. So that's a key point. So it's not that triglycerides aren't important. It's just that you really need to lower them by much greater degree than we typically lower LDL to see any clinical effect, if you believe the implications of these sorts of Mendelian randomization studies, which are obviously not randomized clinical trials. They're sort of nature's way of randomizing people to different genotypes and lifelong exposures to risk factors. So a little bit different than the clinical trials, obviously. There are lots of different potential and existent therapies for hypertriglyceridemia, some of which are listed on this slide, some of which I'll touch upon. But the reality is to really test the triglyceride hypothesis to see if triglyceride lowering really lowers cardiovascular risk. As I said, you really need to lower it by a lot, which none of the currently available therapies or commonly available therapies can do. But there are a number of experimental therapies that are being studied, largely targeting RNA to lower triglycerides, where the triglyceride reductions aren't just 50%, but they're 80, 90, 100% or more reductions in triglycerides. So this series of trials will prove or disprove whether triglyceride lowering per se lowers cardiovascular risk. But as I said, the Mendelian randomization study suggests that enough triglyceride lowering, assuming there's no counterbalancing toxicity, should lower cardiovascular risk. Now, there are a bunch of trials as far as triglyceride lowering, and part of it is that there's been some historical drift, I think, that may have created some confusion. So lots of different ways to lower triglycerides: fibrates, high doses of omega-3 fatty acids, niacin, so a bunch of different ways that will lower triglycerides. But if you look at then the clinical trials of these agents that lower triglycerides, it's been a bit of a mixed bag. Though if you go back in time to trials like VA HIT with gemfibrozil, that trial was positive for triglyceride reduction, but largely in the pre-statin era. But if you look at more contemporary trials, they've been negative. Now, you can sort of come up with subgroups of really high triglycerides, low HDL. Maybe it looked like something was going on, but the overall trials in the contemporary era of fibrates have been negative. Same thing with niacin. In the contemporary statin era, no evidence of benefit. In fact, evidence of harm, side effects, things like that. So really in the contemporary era, statin-treated patient, if the goal is cardiovascular risk reduction, should not be using fibrates or niacin. The guidelines are clear on that. The data is clear on it. It's amazing how widespread the use of those drugs continues to be, despite data pointing to the opposite. And then there are omega-3 fatty acids. And if you go back in time to trials like GC Prevenzione, a modest benefit seen there, but again, largely the pre-statin era, low dose of omega-3 there. And then other trials that I'll review in greater detail, like GELIS and REDUCE-IT, that were positive for omega-3 fatty acids. But the story is a bit complex. Now, if we look at low doses of omega-3 mixtures, for the most part, there's no significant benefit that's been seen in the contemporary trials. Maybe hints of benefit in certain trials, in subgroup analyses, in secondary endpoints. You can certainly, if you're a believer, find if you look hard enough. But overall, in this meta-analysis, no significant benefit of low doses of omega-3 fatty acids. What about intermediate doses of omega-3 fatty acids? And by low dose, I mean about 1 gram a day, like many people take as a supplement, which, as Dr. Marin said, is totally ineffective, but remains a widespread practice. Well, that's low dose that doesn't work. What about intermediate dose? Here, a combination of EPA or eicosapentaenoic acid and DHA docosahexaenoic acid versus placebo in older MI patients. So super high risk population. If it's going to work, you think it would work here, but as you can see, the hazard ratio is 1. So no significant benefit of intermediate doses of omega-3 mixtures. And then there was a strength trial, very well done, large trial of high-dose omega-3, though again, a mixture of EPA and DHA, not a single omega-3 fatty acid, but as is common with the supplements, a mixture. Though this was actually a prescription drug, albeit one that was never launched and then removed because of these neutral data, where the hazard ratio, again, is 1. No significant benefit, and really, at least in the overall trial, no hint of a benefit. So the mixtures of omega-3s, low dose, medium dose, and high dose, in the contemporary era, pretty consistently showing no benefit. And here is a contemporary fibrate trial, prominent, looking at pemafibrate, done by my colleagues while I was at the Brigham. Again, another well-done large cardiovascular outcome trial, the hazard ratio is 1. So for folks that were clinging on to fibrate saying, well, I believe all those subgroups and everything, this trial was optimized for success of a fibrate, and in the contemporary era, statin-treated patients, Didn't work. So really no good reason to use fibrates other than if the trigs are above 500 for pancreatitis prevention or the hope of pancreatitis prevention. But for cardiovascular risk reduction, the time has passed. Let me move on now to other specific therapies that do work, like icosapent which is essentially EPA or icosapentaenoic acid, which is one specific omega-3 fatty acid. This is a pharmacological preparation, IPE, that is highly purified. It's shipped and produced and stored in a way that prevents oxidation, and therefore it's a pure unoxidized version, unlike what you can buy in the store where that stuff is all oxidized and probably of minimal value, even if it's pure EPA or claimed to be pure EPA. Let me start with some Japanese data. This is a CHERRY trial, a small intravascular ultrasound trial, just a couple of hundred post-PCI patients randomized to a medium dose of EPA versus no EPA. It's an open label trial. There was no placebo, but it is randomized, and everybody got a good dose of a good statin. And what you can see here is a significant effect on plaque progression. Indeed, the authors called it plaque regression that was significant with the addition of EPA to statins on IVUS. And even though it was an open label trial, meaning the patients knew what they were getting, the people reading the IVUSs were blinded. So it is a rigorous sort of study, albeit at small size. So this was evidence that EPA, or specifically it was icosapent that was used here, works. That was an IVUS study. Obviously, IVUS is invasive. This is a coronary CT study, and CHERRY was done in Japan. This study, EVAPORATE, was done in the US by Matt Budoff. And basically what this study showed was the same thing that CHERRY showed, except non-invasively. That is, significant differences in favor of icosapent in a variety of different measures of plaque, including plaque volume. So it looked like in two different trials, different populations, that the drug was working. Well, what about clinical trial data? These are data from JELIS, published in The Lancet some years ago. This is, again, icosapent versus control. There's no placebo here. It's open label but randomized, and there's blinded adjudication of the endpoints, a so-called probe design. And at any rate, with 1.8 grams a day of EPA, the dose they use in Japan, a significant benefit in the overall trial in reducing cardiovascular events with what appears to be consistent effects in the primary prevention and the secondary prevention cohort, a hazard ratio of about 0.8, 0.81, so about a 19% relative risk reduction. You'll see here that the rate of events overall, over 5 years or so, pretty low. This is a low-risk population. You know, even the secondary prevention population, about an 8% rate at 4 or 5 years. It's a pretty low-risk secondary prevention and a very low-risk primary prevention population. Half these patients had normal triglycerides at baseline. So this is a low-risk population. It's very different than what I'm going to talk about with the REDUCE-IT trial in a moment. Most recently came, again, from Japan, the RESPECT-EPA trial. And once more, it's an open label trial. It was underpowered, no industry funding. The investigators did a good job doing what they could on their own. It ended up being, as I said, an underpowered trial. That was obvious it was going to be so right from the design. But you can see here, it looks to me like in the primary endpoint, there's an effect. One can quibble about the p-value of 0.0547 here for the primary endpoint, but for the secondary endpoint of sudden cardiac death, MI, unstable angiocoronary revascularization, there with a p-value of 0.03, there's a lower rate with icosapent versus control. So, two separate trials that show a benefit, I believe. This work was published, hasn't been published, but was presented as an AHA late breaker. It's what the first author told me, submitted for publication. And now let me move to REDUCE-IT, which I think is methodologically the most rigorous trial, but consistent with those other data sets as well. And here we took patients at high cardiovascular risk. You can see the event rates at 5 years in these patients, much higher than JELIS in both arms. So we took high cardiovascular risk, about 70% secondary prevention, about 30% high-risk diabetic primary prevention, and randomized them to icosapent or placebo, followed for a median of 5 years. And for the quintuple ischemic endpoint, hard and soft endpoints here, you can see a 25% relative, about a 5% absolute risk reduction. That was very statistically significant. And for hard events, CV, death, MI, stroke, as well, about a 25, 26% relative risk reduction, about a 4% absolute risk reduction. highly statistically significant in the overall trial. And when we look at individual endpoints, first of all 5 components of the primary endpoint were significantly reduced. That is, CV death was significantly reduced, MI was significantly reduced, stroke was significantly reduced, coronary revascularization was significantly reduced, and hospitalization for unstable angina was significantly reduced. So you can see here all those different pre-specified endpoints and a bunch of different composites, all significantly reduced, and even all-cause mortality trended towards being lower. And personally, I think it would have been significant given the reduction in CV death had we just continued the trial longer, which we couldn't financially afford to, or the company sponsoring couldn't afford to do. So that's time to first event, the usual sort of way of doing things. But here we're looking at total events with some help from our good friend Stuart Pocock, who many of you know. He's kind of a faculty member here at Mount Sinai. He's always visiting Dr. Moran and Dr. Fuster and other folks here. And here we're looking at the first event in green. That's why I just showed you that significant 25% relative risk reduction. But also now we see significant reductions in second, third, and even fourth or more events. So what I'm talking about is somebody that has a non-fatal MI and then goes on to have a stroke or a cardiovascular death or something like that. So and overall, if we look at it, then there's about, actually, if you go with our pre-specified methodology, what we told the FDA, we do a 32% reduction in total events in relative terms. But if you look at absolute terms in this patient population of 8,000 patients, about 500 fewer ischemic events. So large relative, but also large absolute risk reductions. Now, that's the overall trial, and since it's a cardiology audience here, this is one of the different analyses that have come out of REDUCE IT. This is one in JACC done by Prakriti Gaba, one of my former fellows at the Brigham, in which she analyzed was patients with a prior myocardial infarction in the past. Could have been a STEMI and NSTEMI. Acute patients were excluded from the trial. So this is sometime in the past they've had an MI. And here you can see the reductions for the primary endpoint, the secondary endpoint. Time to first event in blue is icosapent red is placebo. The lighter shading is time to first event. The darker shading is total events. And you can see it's pretty large risk reductions, both in relative and absolute terms. And if we look at cardiovascular death as an isolated endpoint, as I mentioned, in the overall trial, that was statistically significantly reduced. And here in this subgroup, also it's significantly reduced. And both the relative and absolute risk reductions, I think, are really quite notable. All right, that's all I'm going to say about subgroups. There were a lot of other ones we examined in the trial, but for the sake of time, I'm not going to go through all of them, but just mention that key subgroups for the cardiologist, patients with prior PCI, patients with prior CABG is published in CIRC, large relative and absolute risk reductions, good safety profiles in those patient populations as well. Now, one thing that came out initially in the New England Journal of Medicine paper, probably caused some confusion, was this graph in the supplement where we looked at patients with achieved triglyceride levels less than 150 or greater than 150, finding a benefit in either case of icosapent ethyl versus placebo. But here in blue and green are the icosapent ethyl arms. It looked like those curves were superimposable. So many people concluded, even though I never specifically said from the podium, that, that means triglycerides don't matter. The achieved triglycerides don't matter. Maybe baseline triglycerides don't matter. None of it matters. And that's not necessarily an incorrect assumption, because the mechanisms of benefit here, I think, aren't linked primarily to triglyceride reduction. But on the other hand, interpreting the data really are a bit more subtle. There were other biomarker changes as well, small differences in favor of the drug versus placebo in LDL and hsCRP. Those changes didn't correlate obviously with outcome either, which again, I think made some people uncomfortable because they felt, LDL, CRP, that should be correlated with change. But at least in this population of statin-treated patients and patients getting dietary advice, it didn't seem to. What seemed to really correlate with the benefit was the level of achieved EPA, or eicosapentaenoic acid. The higher the level, the lower the rate of the primary endpoint, as well as various secondary endpoints as well. So that seemed to be really the explanatory variable. The higher the EPA, the greater the degree of benefit. Seemed to make sense, seemed to match up with the prior data and the biology. But then some asked, how does that compare with strength, where that was a mixture of EPA and DHA, and some people did get EPA levels that were, elevated compared to baseline. You can see here, in strength, that mixed combo omega-3 fatty acid did raise EPA levels some. But where the patients got to with EPA was where the patients in the Japanese JELIS study started. So yeah, it raised the EPA, but probably not to the level that one needs to get to, as seen in the JELIS trial for the achieved EPA. It's the exact same levels that we achieved and reduce it. So, whether it's a delta effect, whether it's a threshold of EPA effect, I don't know. But the levels achieved in strength clearly were not enough. And there was some DHA in there that might have been counterbalancing the EPA. But I'll come back to that in a moment. And these are some data I just presented at the European Society of Cardiology a month or two ago. It's called a mediation analysis. So it's trying to figure out statistically what explained the degree of risk reduction we saw. And about 2/3 of the benefit was seen in the level of EPA achieved, as well as arachidonic acid, which is, as you may know, an omega-6 fatty acid believed to be bad and pro-inflammatory and so forth. So yeah, either measuring these levels or the ratio didn't end up mattering, explained about 2/3 of the benefit. And then about another 15-ish% of the benefit could indeed be explained by reductions in triglyceride-rich lipoproteins. And then a bunch of other biomarkers we measured accounted for about 5%-ish or so of the observed benefit. And then the remainder of the 15% or so benefit we couldn't explain with the variables that we saw. So in other words, 80% or so of the benefit could be explained by EPA, arachidonic acid, and triglyceride level changes. So you could say that about 20% or so of the 25% relative risk reduction, we have a clear explanation for. The rest of it, we can't explain right away with biomarkers that were measured in the trial. So why could EPA have such benefits? That could be a talk in itself, but there are believed to be beneficial effects on endothelial function, improvements in nitric oxide bioavailability, changes, I mentioned the EPA-AA ratio, beneficial effects on IL-10, and a bunch of other anti-inflammatory effects that aren't really the ones that you usually think of in terms of CRP or even IL-6. Beneficial effects on cholesterol crystalline domains, on oxidation of LDL, on plaque volume, as I showed from the imaging studies, also on thrombosis and platelet activation specifically. There's a bunch of data that should come out about that'll support those statements, and older data of kind of low quality that support that statement. And I think what's occurred is a real revolution in omega-3 fatty acid research that perhaps a lot of physicians don't appreciate. So sure, you can get omega-3 fatty acids from natural sources. Marine oily fish are the best way in terms of EPA. But for folks that are vegetarian or vegan, chia seeds, flax seeds, walnuts are an okay but not great source because humans are inefficient at converting linolenic acid all the way down to EPA. Estrogen, as it turns out, does help a little bit with that conversion, but still in humans pretty inefficient. So if you want to do it naturally, probably marine oily fish is the way to go. But even that doesn't approach what one can get with 4 grams a day of icosapent-ethyl. So for therapeutic purposes, that's not going to do the trick. So here's EPA, and then through several different enzymatic steps, DHA is produced. Some people think there's retroconversion. It's pretty complex and evolving biology. Not every step is known here. So this isn't like, say, the Krebs cycle where everybody knows it, or maybe everyone's forgotten it, but at one point, everyone who's a physician knew it. And I don't think it's changed. But here, every few weeks, somebody comes up with a different arrow. So this is evolving science. But the downstream products of EPA, in some cases DHA, are potent anti-inflammatory agents, things like specialized pro-resolving mediators, things that you probably haven't heard about. Infectious disease docs have heard about it, but most cardiologists haven't. And, does it really matter, EPA, DHA? I made a bit about this, a big deal about this. Does it matter? Well, just like testosterone and estrogen are just a little bit different, the same is true of EPA and DHA. Yeah, it's a couple of different carbon atoms and bonds. Who cares? Well, in biology, in 3 dimensions, it can make an immense difference. And much like if anyone did a trial of testosterone plus estrogen in men and women and concluded that hormones don't work, well, that would be stupid. The same thing has essentially happened with trials of EPA and DHA in very heterogeneous populations and concluded they don't work. You've got to get the right sort of therapeutic in the right patient population. And that hasn't happened with the omega-3 trials for the most part, though I do think we got it right and reduce it. Now, I mentioned this briefly before, that in strength, maybe the DHA was countering whatever good EPA might have been there. Why do I say that? Well, this is work from Preston Mason's lab in Boston showing that EPA stabilizes cell membranes, and this is in vitro work looking at cell membrane preparations, which is believed to be a good thing. Maybe it helps stabilize ventricular membranes, reduces sudden cardiac death, that sort of thing. Whereas DHA disrupts cell membranes. That's what these squiggly green things are here. So potentially this isn't good for adults in cardiovascular risk reduction. Might have a role in other aspects of human health, maybe the infant whose neurons or retina is still developing. Some people think DHA could be useful there. But in an adult, probably EPA is where the action is for cardiovascular risk reduction in patients with atherosclerosis or high risk. These are some more data from Preston Mason's lab. I'm not going to get into the details of the biophysics here, but it's looking at the electron density signature of EPA here in red and DHA in blue, and you can see very different effects in terms of membrane structure. So just to say, oh, well, omega-3 fatty acids are all the same is clearly not the case. They're having extremely different effects. And I showed you the work from Preston Mason's lab, but just to not show you one particular lab, this is work from Northwestern University, totally different set of investigators. They're just interested in biophysics for biophysics' sake, showing essentially what Dr. Mason's lab had shown, the distinct effects of EPA and DHA on cell membranes. There's also evidence, this is from Preston Mason's lab as well, that EPA improves endothelial function compared with DHA. You can see the effects here of EPA, DHA, and control on nitric oxide release. Some more data showing that EPA increases the EPA to AA ratio in endothelial cells, again, believed to be a predictor of vascular protection. Once more, EPA having a significant effect, DHA much less of an effect, arachidonic acid and control really no effect in this model. And these are some data just published in the Journal of the American Heart Association a few months ago, looking at EPA, DHA, the placebo we used in REDUCE-IT, the placebo that was used in STRENGTH. Neither placebo had any effect in this experimental model of oxidation of LDL, whereas EPA had a significant effect, DHA numerically had an effect, but it wasn't significant. So hopefully some data that are useful in terms of people like mechanistic data. These are some data that have been presented but not published yet from the Mass General from Farouk Jafar's lab, if any of you know Dr. Jafar. He's an interventional cardiologist, but also quite successful doing basic research. And they examined in this lab icosapent ethyl in vivo model. And using serial imaging of rabbits, a modest number, 20, they fed them a high cholesterol diet, induced aortic balloon injury, and then looked at them at 10 weeks. The rabbits were randomized to control or to icosapent ethyl at a dose meant to simulate what it might be in humans. They thought all that throughout. And then they did some fancy imaging. Dr. Stone was talking about IVUS and OCT and all that stuff. Well, here they are doing it in a rabbit. And this is what they found. Here is control, baseline, week 10, and then, or actually week 6, week 10, and IPE, week 6 and week 10. And what they found was effects on rates of plaque progression. And just to jump to what the statistics show, if you're not used to looking at these images, overall, a significant reduction in total atheroma volume with icosapent ethyl versus control, other versions as well, percentage atheroma volume. So it looked like they were seeing in this hypercholesterolemic rabbit model what has been seen in humans in imaging studies that I alluded to earlier. And here's some work looking at inflammation and histology. showing, again, significant effects of IPE versus control in a couple of different markers of inflammation. Not every single one was affected, but 2 out of the 3 here. So then to just summarize some of these data for omega-3 fatty acids, if we look across all these different trials, there's a pretty consistent signal of EPA reducing important ischemic events. Whereas EPA plus DHA, it's a bit more heterogeneity in terms of the trials, the specific endpoints, but overall no clear sign of benefit. So I really do think that the EPA is where the action is. So let me just switch now to a totally different pathway, but one that also lowers triglycerides, so that might not be the predominant benefit, much like it turned out was the case with EPA. And this is FGF21. This is an endogenous stress hormone. It plays a really major role in regulating things like lipids and glucose and energy expenditure. And I'm not going to get too much more into the science of it, other than to say pegozafermin is an analog of FGF21. It was studied in a phase 2 trial. We just published the results in Nature Medicine about a month or 2 ago. And in this phase 2 trial, pegozafermin in patients with severe hypertriglyceridemia significantly reduced triglycerides, about a 50-ish% reduction, at least at the optimal doses, 50 to 60% reduction in the triglyceride levels versus a 12% reduction seen in the placebo arm. So within the context of a phase 2 trial, it was safe and seemed highly efficacious in terms of the primary endpoint, just in 8 weeks. So pretty rapid effect in terms of reducing the triglycerides. Perhaps more interestingly, I presented this as a late breaker at the European Society of Cardiology, and the cardiologists loved it. These are MRIs of the liver. Most cardiologists don't look at that. Shown here is the baseline on the top, week 8 on the bottom. Here is the color-coded explanation. So up here means a lot of fat in the liver, 40%, 30%. Down here in blue means 0%. So up top, baseline, there's a lot of green here. So this is basically, you could say, 30% liver fat in these patients that were enrolled in a trial just because they had triglycerides between 500 and 2,000. They didn't have known liver disease. So this is their liver at baseline. And at week 8, you can see what happens to the liver in the placebo arm. It goes from 30% to 30%. There's no change. But in all these different treated arms at these different doses, it goes from green to blue. So really large and significant and rapid changes in liver fat. And again, these aren't people that had any known liver disease. We were just looking for people with high triglycerides. We did a sub-study with MRI of the liver for fun, and this is what we found. So what that tells me is that, first of all, a lot of these patients walking around with really high triglycerides were worried about the cardiovascular risk, with good reason, but there's also a lot of cardiometabolic risk that's going on. I suspect a lot of these people will go on to develop symptomatic liver disease. So potentially then this drug could be useful in people that actually have things like non-alcoholic steatohepatitis, NASH. And I mean, that's conjectural, but we also just last month came out with another phase 2 trial of patients that actually had liver disease. This was published in New England Journal, showing that at week 24, a little bit longer treatment duration, significant improvement in their livers with the different doses that were studied in that phase 2 trial of pegozafermin versus placebo. So in the GI world, fibrosis improvement greater than or equal to 1 stage without worsening of NASH was seen in a significantly higher percentage of patients than was seen in placebo. And NASH resolution, which is a pretty good endpoint, without worsening of fibrosis, seen in a much higher percentage of patients on pegozafermin versus, well, in placebo, it wasn't occurring. So obviously, both these results in both these populations need to be confirmed in phase 3 trials. With respect to the severe hypertriglyceridemia, there is an ongoing phase 3 trial, the ENTRUST trial, looking at triglycerides. We're participating here at Mount Sinai. Dr. Rosenson is the principal investigator. So if you have any patients with triglycerides between 500 and 2,000, please refer them to him, and he can triage them potentially for enrollment in this trial. But we'll see what happens in this trial. Sometimes, phase 3 trials aren't quite as good as phase 2, but hopefully we'll see a new therapeutic that can lower triglyceride levels and hopefully also have effects on the liver. Whether it has any effects on the heart, obviously that would require a much larger, much longer term study, but we'll see. So to conclude then, I've focused, as I was assigned by Dr. Sharma and Dr. Narula and Dr. Kinney, to one specific axis of cardiovascular risk reduction, one targeting patients with high triglycerides. But as I showed you, there's some overlap anyway with anti-inflammatory and anti-thrombotic effects of some of these compounds. But I imagine in years to come, we'll figure out which patients should really be targeted with these different pathways here. The highest risk patients, I think, will get several of these pathways: cholesterol reduction, inflammatory risk reduction, thrombotic risk reduction, triglyceride risk reduction, maybe Lp(a) risk reduction if those phase 3 trials pan out, and of course, diabetes-related risk reduction. Thank you so much for your attention.